very much.
Thank you for having me. I'm tasked with speaking about right-sided mechanical support in patients with massive PE. The DMC experience is actually very interesting. Our program was started by my colleague and partner, Dr. Elder, in 2011. Since then, we've made significant advances locally at our institution, and one of the things that we're very proud of is that we've we've used this device, the RP. There's been 5 cases done in the country so far based on the IQ database, and we have 4 of those patients. We're going to share with you our data and feel like this may be a potential therapy for some of these patients that otherwise were dying. So we'll start off with the case. This is a 52-year-old female who presented with exertional dyspnea for 3 days. She had recently cellulitis and was immobilized due to her cellulitis. She presented with shortness of breath in the ED, and her only real remarkable finding on exam was that she had tachycardia. You can see her EKG. She was sinus tachycardia with T-wave inversions across the precordial leads. She did not have the typical findings that you would expect in a patient with a submassive or massive pulmonary embolism. The relevant labs, she had troponemia. Her creatinine was within normal limits. Her lactate was a little bit elevated. And you can see her PESI was a 109, which put her at moderate range. Her modified PESI was 8.9. So here's the images. You can see the patient has a submassive pulmonary embolism involving both main pulmonary arteries. It was not totally occlusive. The other significant finding, what you can see is she had significant RV dilatation, and if you look at the ratio of the RV, it's pretty easy to determine the RV is actually bigger than your LV. So when she went, routinely when we do our treatment with our PERT program, we require the patient undergo hemodynamic assessment prior to the procedure, and also we'd like to do it, which we haven't been as successful in, is at the end of the procedure when the EKOS comes out to try to keep our, for our database and looking at what we've done as it relates to the hemodynamics. But this particular patient had a pulmonary artery pressure pulsatility index of 0.94. You can see the mean right arterial pressure, right atrial pressure was 17, and you see the RV and PA pressure. So at this point, we decided to treat the patients with bilateral EKOS catheters. And as a result, the EKOS came out 24 hours later. 3 days into her admission, the patient had started to have hemodynamic compromise, manifested with blood pressure in the 80s, heart rate going up, requiring vasopressors. We took the patient to the lab and did a hemodynamic assessment, and you can see the patient had a pulmonary artery pressure index of 0.56, which is very interesting because it doesn't actually correlate in our other 3 cases that we'll show you. A decision was made that the patient had RV failure as a result of the massive pulmonary embolism, and we decided to treat this patient with right-side hemodynamic support. What you see there is a 23 French going from the IVC, and on the right, what you see is a Platinum Plus, and the Advocate Abumed that you put the wire into the left pulmonary artery, which facilitates getting the device down. So once you have the sheath in, we advance the support device into the right atrium, at which point it's calibrated. And then we advance the device into the ideal position, and you can see here on the right that the device is in the pulmonary artery. So what happened to this patient as a result of this? The patient had marked hemodynamic improvement. The right heart cath we showed you before removal of the impella showed significant improvement in the right side hemodynamics. The patient clinically improved, urine output went up. We'll show you her blood pressure at the end as we accrued our data. But the patient actually survived this hospitalization at day 20 and has been followed up in the clinic. Here's her echo findings. You can see before we put the impella in, you can see the fractional area change is significantly reduced. You can see day 4 of impella, we have mild improvement of the RV function. I think you don't have to be an echocardiographer to appreciate that. And if you look at post-impella, by the time the device was taken out, we had significant improvement in RV function and improvement in fractional area change. So in Detroit, we're known for a lot of things. It's the Motor City, Motown. And now we're paving the way in cardiogenic shock. If you haven't heard of the cardiogenic shock initiative, we made some marked improvements in survival in our early experience of our first 40 patients. This is the kind of flow chart we use in the cardiogenic shock initiative, and I show this only to say, is this the right way that we should be treating pulmonary embolism, or is pulmonary embolism different than AMI shock? And I think based on our limited experience, it may be different. In our cardiogenic shock flow chart in Detroit, if someone has a cardiac power index that's above 0.6, meaning that the left side is not in shock, we look at pulmonary pulsatility index, and if the index is below 1, then we have a very low threshold to use right-sided support, and we feel that that's the, that helps survival. So the cardiogenic shock initiative, I just bring this to say that maybe this is not related to the way we should treat PE, and we can share with you the details if anyone's interested. So I'll share with you our 4 cases that we've done at the DMC. We've used right-sided support for massive PEs. In our series of 4 consecutive patients with massive PE and RV shock that was refractory to inotropes treated with RP as a bridge to recovery, all of these patients were treated for their PE with ECOS catheters. Their baseline cardiac index was 1.7 liters per minute with a mean pulmonary pressure of 42. The average use of the device was 3.7 days, ranging from 1 day to 6 days. All patients treated had significant improvements in hemodynamics by the time of discharge, and all patients survived. Based on our echo findings, 2 of the patients out of the 4 had significant improvement in RV function, and there was no significant change found in renal function, hemoglobin level, and platelets. And I say that because some of the patients had the device in longer, and we didn't appreciate hemolysis as we've seen with the left-sided device. There was no transfusion necessary, although one of our patients had a significant drop of hemoglobin of 13.7 to 7.3 that was related to access site bleeding. If you look at our echoes, if you look at day 1 compared to days 3 and 4, looking at 3 parameters, just looking at RV function using apical 4-chamber, looking at fractional area change and the traditional TAPSE, you could see all the patients without exception had improvement in TAPSE, had improvement in their fractional change, and some of the patients, 2 of the patients actually did not have improvement on the 4-chamber assessment using Simpson's. What about their vital signs? I think this is probably what we learned. The most important thing that we learned is if you look at the PAPI across these 4 patients, there was actually no correlation. And historically, we've used PAPI, and I think that maybe challenges us to say maybe that's really not the right way to assess RV function when patients have pulmonary embolism. I think based on our experience, what we can conclude is that if you use hemodynamic parameters, particularly blood pressure and heart rate, the device has actually showed significant improvement in recovery if you just look at blood pressure by the time that we put the device in and at the time the device was removed. So it's suggesting that the patient is no longer in shock and had significant recovery of the RV. Looking at right-sided CAS before and after the use of the device, you can see that we had improvement only in that 1 patient. The other patients, we didn't acquire the data, unfortunately. But in that 1 patient, you can see patient number 4, the cardiac index before and at time of explant was significant. Unfortunately, we don't have the other data that would have been very useful. So in conclusion, based on our experience, this device provides mechanical support for patients that suffer from PE complicated by right-sided heart failure, despite being treated with catheter-directed therapy. There was a poor correlation, although the N was very small, between the pulmonary artery pulsatility index and acute right heart failure. The adverse event rates were very low, although it's a small number of patients. We think we demonstrated that technically it's very feasible and safe to use an Impella RP and ECOS catheter simultaneously in the same patient. Further study is warranted. Obviously, this is a small number. With that, we conclude, and happy Father's Day, everyone.